Okay, we're going to do the end-of-life anatomy and the aging population. A quick overview of the end-of-life choices before we begin will develop further on in the presentation, but the end-of-life decisions for seniors involve the individual or the representatives, especially in the cases of terminal or chronic cases, and the options like palliative care, assisted suicide, and euthanasia raise ethical concerns as requiring a balance of autonomy and societal responsibility are influenced by factors of demographic, socioeconomic, and institutional concerns. That being said, they may act as barriers that may restrict the ability of certain individuals in the aging population to be able to make some of these choices. This is a controversial topic within its nature, and that being said, this presentation will not take an argumentative format, but more of an academic piece that will provide further insight within this aging population and the special issue of euthanasia and assisted suicide. Now, there are different types of end-of-life decision. Furthermore, euthanasia, there are different forms, which are active and passive. And active euthanasia refers to the administration of a lethal agent by another person to a patient for the purpose of relieving the patient's intolerable and incurable suffering. Active euthanasia is illegal in all 50 United States. This quote was found by George Inferno, 2015, page 387. Passive euthanasia, PAS, or aid in dying, involves a physician providing the means or information for a patient and their life. PAS is illegal in 5 states: Oregon, Washington, Montana, Vermont, and New Mexico, with varying conditions in each state. Next, we're going to be looking at palliative care and hospice. Now, palliative care prioritizes quality of life for those with life-threatening illnesses and their families without aiming to speed up or delay death, and can be used at any illness stage. This quote was found by Morgan and Kunkel, 2015, page 216 to 217. Whereas hospice care is a type of palliative care which focuses on comfort rather than cure, using pain management and holistic approach to support both the dying person and their loved ones. That being said, palliative care and hospice are more acceptable in society as an end-of-life decision rather than PAS, which it may be legalized, but there are more controversial issues with that. But it should be noted that the difference is that while hospice is a form of palliative care, it is intended for individuals living 6 months or less when there are no other effective treatment options available, such as in the instances of chronic illnesses of cancer and dementia. Whereas palliative care can be at any stage of illness and is comparable to treatment to alleviate symptoms of pain. Therefore, there are more of a high chance the patients may recover in a palliative care setting rather than in a hospice. Now, it should be noted that from George Inferno, 2015, page 380, it states that hospice care involves stopping life-sustaining treatments and is not considered euthanasia or PAS, as euthanasia, as previously mentioned, is a form of administration from another individual towards the patient, where hospice and palliative care is more on the patient refusal of medications, for example, by the patient's own doing, but it is all voluntary. Next, we're going to be looking at the impact of demographics on end-of-life decisions, as EAS considerations are often influenced by age, with older adults being less likely to utilize it. That being said, this quote from Narnian, Chantarskarian, 2025, page 8, states that registry data from Belgium, the Netherlands, and Switzerland show that EAS is less common in younger individuals stable between 30 and 60 and decreases of age, particularly among women in Switzerland. Therefore, there are different age groups within the aging population that may have different perspectives on whether or not they accept or don't accept the issue of end-of-life decisions and choices. And this is based on generational differences in religious standards, in which we will develop again furthermore in the presentation. Next component is gender. Now, gender is formed by patriarchal roles that shape and end-of-life decisions, deepening inequality and suffering, particularly among women who are more seen as caregivers, may avoid care within themselves to avoid burdening others, while men are less likely to seek help, may prefer home care or even euthanasia. And these societal norms worsen disparities in aging, illness, and death among men and women within their lifespan. Now, this quote was found from Narnian, 25, page 13, which states that societal norms pressure men to appear tough, leading them to view palliative care as weakness. Gender norms shape how both men and women approach illness and care. The next quote is found by Narnian, 25, page 16, which states that studies show women are less likely than men to request life-extending treatment, often due to concerns about being a burden, and are more likely to have early DNR orders. DNR orders stand for do not resuscitate. Now, from these quotes, we can see that, particularly examining women, that the fear of burdening others can significantly influence their end-of-life decisions, which may lead to the premature acceptance of care options that may not fully align with their true desires, and as a result of gendered expectations around the narrative of caregiving and dependency, further complicate how women navigate their end-of-life choices. Now, this quote, founded from Narnian 25, page 17, states that, quote, women live longer but face more years of disabilities and cognitive impairment, often outliving their spouses. They lack caregiving support. Evidence shows women who are primary caregivers are less likely to want to die at home to avoid burdening their children, end quote. Thereby gives more insight towards the issue that women are more likely to sacrifice themselves to be a caregiver to others, but when it comes to themselves, they furthermore neglect their own care and are more acceptant of institutions of palliative care and hospice being the ones that take care of them, instead of being more reliant on the social support system of their families or friends. Next, we have the dying trajectories and chronic illnesses, which is important to be able to know because, as we had previously mentioned, PAS is legalized in certain states, but that does not mean that it is open to every single individual, but there's criteria to be considered, and the dying trajectory is one of those considerations. As this quote from George Inferno, 2015, page 387 states, this study identified 2 key aspects of dying trajectories: duration, time from illness to death, and shape, symptom spikes, recovery, decline. Researchers generally agree on 3 typical trajectories: study decline of terminal phase, cancer, gradual decline with acute episodes, heart failure, and prolonged decline, dementia. Now, we are going to be just examining the 2 trajectories, which is cancer, terminal illness, and prolonged decline, dementia. Now, In Oregon, PAS was more common among those with ALS or cancer. In Switzerland, older adults with cancer, neurological, or respiratory disease choose PAS. In Spain, 2.5% of terminally ill palliative patients wanted euthanasia with higher well-being scores. Poor health and suffering linked to fluctuating acceptance of PAS/EUT. This quote is from Castelli, Transtart, 2021, page 9. Now, it should be noted that because poor suffering and health are factors towards accepting PAS/EUT, that does not mean that those who suffer more due to symptoms of aggressive cancer are always going to choose end-of-life decisions, because they may not have that ability based on certain barriers and factors like religious components, which we will again talk about furthermore. Next, we'll be looking at cancer versus Alzheimer's disease and the trajectories and challenges it faces. Now, if we look at figure 2, we can see Chach and Shega, Cox, Haley, 2004, death trajectory in cancer and AD, with the first picture showing the declination of cancer within an individual going steady down within time, whereas the progressive nature of AD is in figure 2. Now, there's perception of barriers in end-of-life care, as cancer is more seen as a clear cause of death, while dementia's gradual progressive complicates this view. As a result, dementia is often not treated as a directive cause, limiting access to palliative and hospice care. Now, this quote was from Shega and Cox Haley, 2004, page 4, which states that pneumonia, cardiac, and cerebrovascular diseases are more common causes of death for both demented and non-demented individuals. In advanced dementia, issues like apraxia, dysphagia, and reduced mobility increases risk, with dementia seen as a contributor factor rather than the direct cause of death. Now, cancer's progressive is predictable, while AD complicates pain detection. Caregivers often face this burnout and dementia symptoms, but this may also pressure patients in their end-of-life decisions, as the change within AD may be in towards their reluctance of declination of memory, which therefore that is why there is more advanced directives and guardianship for those individuals. That being said, when it comes to the factor of burnout, caregivers face, they may see end-of-life choices as being more acceptable in this case because of their burnout they may face, which leaves patients with AD more susceptible to corrosion and not being able to make that true end-of-life decision that they want. Next, we're going to be looking at the financial incentives of end-of-life care, as financial incentives in healthcare hinder palliative care, particularly for dementia patients in nursing homes. Providers avoid end-of-life care due to lack of reimbursement for extra staffing, leading to transfers to hospitals that financially benefit facilities but may not improve care quality. This was found from Shega and Cox Haley, 2004, page 10. Now, this shows that the emphasis on medical interventions rather than patient-centered care can result in neglect, particularly during the critical stages of certain diseases such as dementia, and therefore is not a true end-of-life care that they may receive within their quality. Next, we're going to be looking at the inadequate palliative care for dementia, as despite growth in palliative care and end-of-life research, dementia patients still receive inadequate care, often remaining on feeding tubes with untreated pain. In 2001, only 7% of hospice patients had dementia, highlighting the care gap for the growing population, found from Shega and Cox Haley, 2004. Now, the illness trajectory shapes treatment for cancer and AD, but societal views create disparities. AD patients often face barriers to end-of-life choices, limiting their control over their care and the ability to make certain decisions, in contrast to those who have cancer. Next, we're going to be looking at the mental health disorders and EUT/PAS, as a controversial view on mental health disorders may support allowing suicide for those at risk, potentially creating what is known as a slippery slope, which is what most people that disagree with the utilization of EUT and PAS use as an argument, because this would expand end-of-life criteria, leading to a more normalized practice of euthanasia or assisted suicide. Now, E/PAS may risk individuals with psychiatric disorders or suicidal tendencies, especially women, due to overlap with suicide attempts. While men use more lethal means, women, particularly of European descent, make up half of assisted suicide cases. The risk increases with debates on allowing elderly individuals, even without illnesses, access to E/PAS. This is found from Scoppi, 2003, page 4. Now, we're going to look at the impact of depression on EUT/PAS, as depressed individuals are more likely to support EUT/PAS, but treatment reduces the support, emphasizing that the need for mental health care in assessing end-of-life choices to ensure that the individual is well-informed and making stable decisions. As quote found from Castelli, Transtart, 2001, page 10 states that depressed older adults are more likely to support EUT/PAS, especially in terminal or coma scenarios, though support decreased with treatment. Anxiety and lower life satisfaction in functionally impaired individuals were linked to more support for EUT/PAS. Next, we're going to be looking at the cultural and ethnic considerations. Now, religion heavily shapes end-of-life choices, with faith and family pressure influencing views on euthanasia or assisted suicide. This can cause conflict and distress when decisions reflect others' beliefs over personal wishes. We can find this quote from Castelli, Transtart, 2021, page 12, which states that religious older adults are less supportive of EUT/PAS than non-religious ones. Unaffiliated individuals and Protestants are more likely to support EUT/PAS, while Baptists and Calvinists are less likely. Strong religious commitment reduces support for PAS/EUT, with spiritual patients less likely to seek EUT. Next, we're going to be kind of looking at the global perspective, as we look at figure 3 from Colombo AD and Dalla Zuna G 2024. We can see the death toll for EAS, and we can see that within the certain legalization states that it increases throughout the years of the euthanasia and assisted suicides. Now, the graph illustrates furthermore that even though the usage increases in the countries that have legalized it, there are cultural barriers that enact the acceptance of its legalization, such as cultural taboos, moral objections, and the fear of societal disapproval can deter individuals and healthcare providers from participating in or supporting its practice. As this quote from Montreal and Tripathi 2022, page 5 suggests that the 1991 Patient Self-Determination Act highlights cultural differences in autonomy, and the U.S. autonomy empowers, while in Korea it burdens collective decision-making. Toleration may increase autonomy in collectivist cultures. Western cultures fully disclose illnesses, while others avoid death discussions, and views on pain vary, with some seeing it as a test of faith. Thus, these demographic factors shape how end-of-life issues are perceived and addressed, particularly among vulnerable subgroups. Next, we'll be looking at the social inequalities and end-of-life decisions. Looking at the socioeconomic status, quote from Casale Transtar 2021, page 19, states that higher income socioeconomic status are linked to more favorable attitudes towards PAS in older adults, who are also more likely to choose PAS. Financial constraints may lead depressed hospitalized patients to refuse previously desired treatments. Now, financial hardships can pressure vulnerable adults into decisions that don't reflect their true preferences, highlighting the need for healthcare systems to prevent financial barriers in PAS and end-of-life care. Now, from Figure 4 from Casale Transtar 2021, page 9, it shows race and ethnicity for PC and non-PC patients, which shows that palliative care is more common among Caucasians, while minorities face barriers that play a role in their ability to fully gain insight into end-of-life decisions. And we can find this quote from George Inferno, 2015, page 384, which states that ACP rates are lower in Blacks and Latinos than whites due to factors like limited resources, language barriers, cultural beliefs, distrust in medical institutions, and religious views. Some also prefer all interventions and view living wills as unnecessary. Next one, looking at the financial hardships, we can see that the cost gap arises from systematic neglect of marginalized communities, where limited care access leads to higher costs and ineffective treatments, reinforcing healthcare disparities and burdening vulnerable populations with unnecessary expenses. When examining the disparities in healthcare, resources for non-whites are misallocated, with fewer life-extending treatments and more aggressive end-of-life care. Mistrust, economic barriers, and inconsistent care limit their choices, while Blacks receive lower quality primary care, leading to higher costs and more hospital use in their final months. This quote was from Hanchanti, 2009, page 5. Now, in consideration of race and gender, it's essential to recognize how intersecting disparities in race, gender, and other social factors can place individuals in a position of double jeopardy. These combined disadvantages can limit access to quality care and affect end-of-life decisions, making their experiences even more challenging. Now, this quote was from Sun T. 2024, page 7, which states that white men receive the best end-of-life care, while Black women facing race and gender disadvantages receive the worst care, often due to lower income, less prestigious jobs, and higher vulnerability to discrimination. Next, we're going to be looking at the subgroups of seniors. Now, when looking at the generational shifts and attitudes towards EUT and PAS, as liberal baby boomers and younger generations gain influence, support for euthanasia and assisted suicide is expected to rise, driven by values of personal freedom and autonomy. This quote was from Marsala, 2019, page 3, which states that cohorts influence social change by shaping attitudes based on their characteristics and historical context. Ryder, 1965, argued that the larger, younger cohorts drive progress. Baby boomers, 1946 to 1964, notably impacted issues like abortion, same-sex marriage, and end-of-life care. Public opinion shifts are due to generational replacement, with boomers' liberal views contrasting with older generations. Next, when looking at religious and secular views on end-of-life decisions, when looking at older seniors, particularly religious generations, tend to have more conservative views on euthanasia, though spiritual beliefs may still influence non-religious seniors, whereas in younger cohorts, their more secular generations prioritize personal autonomy and generally support euthanasia and assisted suicide, with some still influenced by spiritual practices. This quote was provided by Marsala, 2019, page 4, which says that many non-religious individuals still engage in spirituality, such as prayer. Post-baby boomers who pray are more supportive of euthanasia, reflecting a shift towards non-traditional spirituality. Conservative religious groups resist secularization, lowering euthanasia approval, while progressive groups are more accepting. Thus, understanding the qualitative experiences of different subgroups can offer insights into how seniors navigate complex issues like euthanasia. Next, we're going to be looking at the legal and ethical frameworks. Now, this quote was from Casale Transtar 2021, page 8, which states that legislation mandates that UT and PAS requests be voluntary and free from pressure. In Belgium, UT is legal for mental health disorders, dementia, or advanced directives, regardless of terminal illness. The Netherlands is considering extending UT to those who feel their life is accomplished, potentially affecting older adults. Now, countries have legalized UT/PAS have criteria which we have stated further on, but some groups risk exploitation or premature death, such as those who have depression or mental health disorders. That being said, safeguards like advanced directives must protect seniors' autonomy while preventing manipulation, balancing safety, and informed decision-making. Now, this quote was founded by Manderfield and Wilbur, 2025, page 8, which states that stress the need to balance autonomy and safety in elder care. Overly strict measures like guardianship can harm mental health, while too little support raises safety risks. Legal actions may also cause emotional and financial harm, end quote. That being said, this is my policy recommendation, as the implementation of longer mandatory waiting period between the request for euthanasia and the procedure itself would allow the person to reflect on their decisions, thereby lessening the likelihood of coercion from families to distort their choice. This quote was founded from Wright, 2023, page 5, which states that, additionally, MAID laws typically require a 15-day waiting period between requests for this end-of-life option. Some states have recently reduced this to 48 hours. That being said, implementing safety measures for end-of-life decisions that reflect the preferences of all parties involved and offer insight into how choices may change as illness progresses, allowing for documentation of the elderly's prior wishes, ensures a transparent, well-documented decision-making process to prevent this abuse or corruption to occur. Therefore, this quote founded from Taylor, 2024, Manderfield, and Wilbur, 2025, Page 8 suggests that the safety autonomy grid balances safety and autonomy for older adults, considering protection of personal freedom. It supports flexible, value-driven decisions, allowing adults to express preferences while caregivers adapt to changing needs. These principles may help prevent premature death under external pressures, offering time for assessments, interventions, and education on prognosis and emotions. Thus, strong policies and supportive social structures are necessary to improve the outcomes for seniors facing end-of-life decisions while protecting their autonomy and well-being. Next, we're going to be looking at the personal narratives and voices of the elderly. Now, this quote was founded on CBC News, the National 2014-408, which cites that I think keeping people alive when there's no longer any joy or life in them is cruel and unusual punishment. And I think we should start thinking of that as we think of the end of life. This next quote was also founded from CBC News, the National 2014, page 456, which states that there's an old saying, no man lives unto himself, and no man dies unto himself. I think this excessive individualism of our society, which says, I'll make my decisions and to hell with the rest of the people, is not a goal, because there are people who care about you. Next, we'll be looking at the voices of vulnerable populations in which terminally ill individuals, such as this man founded from the Press Democrat 2021, page 116, is going through skin cancer. He felt compelled to make the end-of-life decision due to pain and loss of control he was experiencing, highlighting the challenge seniors with chronic conditions face in maintaining autonomy over such choices. Quote, so there's no other way out. I'm going to die, okay? So now I have an option. Either I let the cancer do it, or I jump ahead and say, hell no, I'm going to win this race or whatever battle war. Next quote is founded from Bond 2022, page 2, which is from a 54-year-old man in Ontario, applied for the main program, feeling his financial situation and chronic back pain disability left him with no other option than to look at me. Quote, I don't want to die, but I don't want to be homeless more than I don't want to die. I think we actually have the wherewithal for that not to be an issue, and that we are choosing to help the most vulnerable members of our society is tragic, shared Farshad. Now, this view highlights how poverty and neglect may push low-income elders towards MAID, viewing societal failures and supporting them, and their influence of death being seen as a last resort. Thus, seniors' perspective offer a valuable insight into proving policies and care practices related to end-of-life choices and varying views on the acceptability of the right to die. Next, we're going to be looking at the theories of end-of-life decisions. Focusing on the feminist theory, we can see that ETS 2006 outlines 4 key premises of the critical feminist perspective. 1, women's experiences are socially constructed. 2, the issues faced by old women aren't solely individual. 3, disadvantages accumulate over time. And 4, the feminist poverty is tied to the intersecting oppressions of race, class, sexuality, and the nation. Founded by Sutherland and Angel, 2011, page 27. Now, the application of how it is to UT and PAS connects as the feminist theory shows how gender shapes view on euthanasia, with women's living longer and social rules often limiting their end-of-life autonomy. Next, I'm going to be looking at the life course perspective, which is founded from Morgan and Kunkel 2015, page 14, which states that a life course perspective on aging examines how historical time, personal experiences, choice, interactions, and social forces shape aging. It focuses on life stages, transitions, and how individual and societal factors influence each phase. That being said, the life course perspective shows generational views on EUT/PAS differ. Older adults value family care, while younger ones see it as a personal right, reflecting changing social norms. And lastly, we'll be looking at the aging stratification theory, as Marshall 2019, 651 states that the theory explores how cohorts and historical periods shape aging, focusing on groups of older adults rather than individuals. It highlights how shared life stages and contexts influence behavior, thinking, and actions among different groups. Now, the age stratification theory can be applied as it shows how age shapes access and attitudes towards EUT/PAS, with older adults often facing restrictions that reflect societal devaluation and generational divides based on cohorts. Now, it should be noted that these are just 3 of what I found the most primary within the end-of-life decisions, and there are certainly way more that I could have included, but these were the ones that I felt were more important and prevalent within my presentation that spoke up more. Now, we're going to be doing my conclusion, which the summary of key issues is the aging adults are influenced by demographic, socioeconomic, and institutional factors when making end-of-life decisions. Respecting autonomy and end-of-life decisions while preventing abuse is crucial. Global versus local approaches. Tailoring recommendations for low-income, disabled, and culturally diverse seniors is key to fair end-of-life care. Recommendations. Policies that ensure dignity and informed choice for seniors, address inequalities and access to end-of-life care through healthcare reforms, and encourage family and community involvement to support senior choices. And that is the end of my presentation. I hope you guys enjoyed.